بسم الله الرحمن الرحيم. بالحقيقة ده شرف ليا. It's my great honor and the privilege to be with you tonight in this kidney care management program, which is one of the activities of the Egyptian Society of Nephrology and Transplantation in collaboration with Novartis Pharma. And as you know, it is very important in this era, especially of COVID, to still taking care of our transplantation patient and tailor what is suitable to them in that special era, which we hope that will vanish rapidly when the vaccine will be distributed all over the world. It's my great honor to have 5 speakers in this night. We'll start by Professor Ahmed Al-Khourai, Professor of Nephrology and Medicine and Transplantation in Alexandria University. And Professor Ahmed has got many publications and many activities, and he is also responsible of the guidelines for number 2 and number 3 that will be issued through the Egyptian Society of Nephrology and Transplantation by the end of this year. And Dr. Ahmed will be speaking today about transforming transplantation and the iBox. Dr. Ahmed, please. We will start after 30 seconds of break.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. It's nice to be tonight all together in this very respectable kidney care program. And actually, I'm honored and flattered to be among the distinguished national and international speakers with our president, Professor Hani Hafiz, moderating this very nice, hopefully, program and mentored by Novartis for their generous keeping on for the science and development of the practice in transplantation. Our topic today is a real awaited and looked for maybe for a couple of decades, an item which we craved for as transplant physician is how to assess our patient, how to predict our patient scenario. It's really transforming transplantation. It's the paradigm shift from short to long-term outcomes. We've been all knowing that the main hurdle for the successful transplantation is the long-term outcome, not the short-term outcome. So let's look for the unmet needs and why long-term outcomes are essentials. These are simple risk factors or several factors that affect long-term outcome in transplantation. As you can all see, these can be pre-transplant, peri-transplant, and post-transplant. And pre-transplant, we look for the quality of the donor and the quality of the recipient, how long he's been on dialysis, what is the donor age, what is the metabolic comorbidities, and what is the immune status, whether the pre-sensitization DSAs or PRAs or the match in the HLA between the donor and the recipient, as well as the recipient age. In the peri-transplant, the cold ischemia time for the cadaveric transplant and the delayed graft function with the multiple etiologies that might lead to its occurrence. But we're going to focus more in the post-transplant period, as it is the let's say, the modifiable risk that we can manage to do. Actually, in post-transplant period, not only the graft function, it's also the occurrence of proteinuria, the toxicities, the infection, the malignancy, the cardiovascular outcome, metabolic outcome, diabetes, post-transplant, diabetes mellitus, and hypertension, or even the recurrence of native kidney disease. All these lead to unfavorable long-term outcome, such as renal dysfunction or even graft loss or graft loss due to patient death with a functioning graft. Moving forward, these are the leading causes of long-term graft loss post-transplant. As you can see, almost half of these is death with a functioning graft, and this, again, usually is due secondary to cardiovascular disease or malignancy or sometimes infection. Comes next to this is chronic allograft nephropathy, this terminology that we eager to change, as it does not describe specifically a specific situation, but it's a rather sum of many of the immunological and non-immunological pathways that culminate into renal impairment and loss of the graft with over the time. Then comes hyperacute rejection, glomerular diseases, and non-compliance from the patients and others. The long-term outcomes continue to be poor despite improvement in the short-term outcomes. We've known that for years and years. CNIs are still the cornerstone, and even the trial of CNI elimination was a failure, as we all know. Maybe minimization is the current protocol, in spite of them having the toxicity, mainly the nephrotoxicity, and the increased infection risk, as well as the metabolic complications, whether the atherosclerosis, the diabetes, the hypertension, and others. And that's why we do still have these whole factors working to shorten the graft outcome and maybe the patient life, and we might culminate into death with a functioning graft. And the immunosuppression utilization pattern did not change a lot for 10 years. Maybe you know the milestones of changing immunosuppressive agents in transplantation, starting from the steroids, then azathioprine, then comes the CNI at the 90s, and then we stayed for a while till the MPA or MMF when they were introduced as a replacement for the azathioprine, and then the mTOR comes later, and we still lagging a lot, both in induction and in maintenance immunosuppression. As you can see, we still are working with the interleukin-2 receptor antagonist and T-cell depleting IMPA, CNI, MPA steroids, and maybe lately mTOR, low-dose CNI, and steroids. The different strategies that have been adopted to reduce the CNI-associated toxicities in the long term were not so much successful. As we've said earlier, CNI elimination is not successful maneuver, so conversion is not accepted, but maybe it is minimization and along CNI with mTOR inhibitor, as have been nicely shown by the Transform trial. Then there is a long-term need for the balance between over and under immunosuppression, and we have seen a lot those. So I'm sorry for this technical error. We are back now. And it was that we still need an urgent need for therapies or strategies to balance the over and under immunosuppression. As we were saying, we have all met those type of patients that you think that he is over immunosuppressed, but you cannot hold a grasp upon that. The patient is cachectic, maybe he's underweight, his trough levels are accepted, his renal function is borderline, but the patient is not doing well in himself. We need a strong model that can guarantee the proper status of the patient, that can, let's say, predict the outcome of the patient between over and under immunosuppression. So this is a long-term need in the transplant society. And this is transforming transplantation using the iBox predictive tool or risk scoring system. And the need for this predictive tool has been long-lasting, discussed in many meetings and even clinical discussions between transplant physicians. We lack a robust, widely validated prognostication system and the regulatory agencies in 2018 and the medical societies identified that we need this. Currently available prognostic scores mostly predict allograft survival during transplantation, but it cannot be used to predict allograft allocation at the time. And the parameters such as estimated GFR, proteinuria, histology, and HLA antibody profile cannot provide a sufficient predictive accuracy when used solely. If you use each one of them by himself or by itself, it's not enough. And currently, there is no scoring system that have been evaluated in a large cohort across different countries and different clinical scenarios and different patient ethnicity and types to be validated, to be used in clinical practice. So this is the need for that tool. And this is the current state of art. If you look for the prognostic system in transplantation, level 1, which is just looking for the prognostic score of a transplantation, you can find a systematic review on a number of 410 trials. If you go to the level 2 and you look for long-term allograft survival, it's only 10. If you go for the level 3, which is externally validated and structurally and functionally validated parameters combined together, you'd find only one publication. For level 4, 5, 6, 7, and 8, unfortunately, there is no studies to look for multidimensional assessment, unselected prospective design, mechanistically informed trials, transposable, updatable at different times point post-transplant, not only the early first year, but maybe at 3, 5, 7, and 10 years post-transplant, and even addressing the response to treatment so that you can anticipate what will happen if you give a specific patient a specific treatment, and meeting the Prentice criteria for surrogacy. That's to say, you need to have some sort of personalization with these anticipated systems. Unfortunately, we don't have this, or yet. So let's have a look. Can we be missing something? Is there any new news that something like this, let's say, dream could be available in the near future? This is the idea of the iBox, and we're going to have a short tutorial about the iBox now. Please go in with the video.
Every year, nearly 90,000 patients undergo a kidney transplant worldwide. Following the first transplantations in the 50s, allograft survival improved tremendously, with the graft surviving longer and longer. However, there has been no improvement in the survival rate over the past 20 years. And today, 20% of patients lose their new kidney within 5 years of transplantation. These patients must be put back on dialysis whilst they return to the waiting list, hoping for a new transplant. So we need to extend the survival of transplanted kidneys. To achieve this, patient monitoring after transplantation should be improved with an individualized understanding of the graft evolution and a personalized treatment. At the Paris Transplant Group, we investigated this by learning from historical records of more than 7,000 patients. For each patient, we collected more than 50 parameters, including histopathological, clinical, and biological data. And among those, we identified 8 parameters in our model that are able to accurately predict the graft survival. We have computed these parameters into an algorithm named iBox. For each transplanted patient, we are now able to predict their probability of graft survival at 3, 5, and 7 years ahead. The iBox has been tested on an external cohort of 4,000 patients and in 3 additional randomized clinical trials. The iBox risk prediction score has been proven to be highly reliable for patients, male and female, from Europe and the US, from different ethnic and social backgrounds, from different allocation systems, covering distinct clinical scenarios, and with different treatment. The iBox is the most validated score available in transplantation. The team at the Paris Transplant Group developed the iBox to guide patient monitoring and made it adaptable to most clinical scenarios, aiming for longer graft survival. Also, for the next generation of clinical trials, the iBox could accelerate the development of novel anti-rejection treatments, help researchers design new studies, and also constitute a valid and early surrogate endpoint. This would accelerate the development of novel anti-rejection treatments. Get further information about iBox in the publication from Alexandre Lupi and his team. Every year.
Okay, so after this short video that have given an idea about the iBox risk score system, we're going to go through that system. Actually, this is a very elegant study that have been, of course, entitled in the clinicaltrial.gov. And this study is driven by Alexandre Lupi in France and the PTG, the Paris Transplant Group, where they have a derivation and validation study. It's a prospective study that included initially 4,000 patients from the Paris Transplant Group from 4 centers, and then they have 2 independent validation cohorts, one from the US and the other from France as well, and from Europe as well. And so they have a total of 7,557 patients. They followed up those patients from 2004 till 2012, and the median follow-up was 7.12 years for those patients. They had a 32 prognostic parameter taken into account, and they analyze each of these parameters by itself to find a risk stratification scenario for this. And they have built that risk stratification. Then they have adjusted this, and they did the collinearities and the independencies, the confounding parameters, to find out which are the more specific. So they came out with 8 clinical parameters at the final model. They had a time from transplantation to evaluation risk, eGFR, proteinuria, interstitial fibrosis and tubular atrophy, microcirculation inflammation at the PTC glomerular, interstitial inflammation and tubulitis, and transplant glomerulopathy, and anti-HLA donor-specific antibody as measured by the mean fluorescence intensity. And they did a statistical methodological application using the Cox regression model and the random prediction model for survival. And they have a significant C index of 0.81 with a very high confidence interval between 0.8 and 0.83 for the parameters used. And the prediction, this is the initial paper that was published in September 2019 by Alexandre Lupi and his group, and the PTG group, the Paris Transplant Group, in the British Medical Journal. And you can find here in this statistical model, the linearity is very close in the European validation cohort and the North American validation cohort to the mainstream line, so that you can find that at 3, 5, and 7 years, the iBox algorithm score was almost identical with the linear line, which means a very high efficiency in anticipating the risk score. And this was the performance of the iBox algorithm in different clinical scenarios and different subpopulation of the patient types. So it was used in different functional immunological parameter, different histological diagnosis, instead of using the Banff lesion, in a stable patient during protocol biopsy, in unstable patient during BBAR biopsy, for example, or biopsy for whatever cause, in the first year post-transplant, after the first year post-transplant, in living and deceased donor, in highly sensitized and non-highly sensitized patient, in when adding transplant baseline characteristic in patient with anti-basiliximab induction or those with ATG induction in African American population and in Caucasian or non-African American, in adding recipient blood pressure profile and adding CNI blood trough level concentration. It's almost all the puzzles that we are facing during transplantation. And you can simply find that the C index is almost identical and the confidence interval is very close in all situations, which means that it is really reproducible algorithm. And the validation was done in informed data sets by medico-economic systems, in a biopsy instead of Banflesion, in DSA information, in protein creatine ratio by dipstick, in measurement, in a functional assessment, and even if we have some missing data, and the validation again was excellent all through the status. The iBox performance and validation in therapeutic settings thus showed that at the time of transplant, the iBox worked well with the acute antibody-mediated rejection or the T-cell-mediated rejection or the CNI minimization protocol. In the interim period, the iBox worked very well as well. And even in the late period with the allograft loss in each of these situations, the anticipation was almost accurate. And the therapeutic interventions to modify the iBox risk score were as well validated. There was good agreement observed between the iBox prediction model after therapeutic intervention and the actual observation of the kidney allograft loss. Whenever you did an intervention, like you give a rescue therapy, you give in antibody-mediated rejection, you give, for example, plasmapheresis, IVIG, or rituximab. In TCMR, you give ATG or whatever. In CNI minimization models, you find that the anticipation and the clinical outcome were very similar. And this is very strong point again. And the patient trajectory based on the assessment, again, of their risk was very, very clear. And you have like 11,000 patients, and you have like 115 eGFR measures. And along the different latent classes of those patients, you can find a very nice alignment for each trajectory of these patient situations. And this all led to let's say, again, similarity between the machine learning, how to tackle the heterogeneity in the transplant glomerulus, again, was shown that in different difficult clinical or histological scenarios, the iBox worked very nice. This was a statement by Alexander Luby that he mentioned in the video, that algorithms will not replace doctors. However, doctors who use algorithms will replace those who do not. So we need to know how to get the best use out of these algorithms and start using it in our clinic. Okay. So sorry again for the technical problem. And we were just saying that there were 3 large cohort studies that have shown the validation of the iBox algorithm in anticipating the prognosis. And actually, this have led to to anticipate what's going on. We can go ahead directly and find out what's going on by anticipation with a tool such the iBox, early surrogate endpoint to predict patient individual risk. That's to say, it is individualization, and it can be used even 0.9, 0.8, and 0.94 in all 3 studies. And this again has been extrapolated to the reduced CNI versus standard CNI, and the iBox algorithm have shown a solid outcome that it should study. Of course, because of the time constraint, we cannot go through a specific data of the study, but you can find here from the non-inferiority study that there is almost similarity, and the iBox has anticipated this in 3 years, in 5 years, and in 7 years, and this is by extrapolation. The 10-year study is an extrapolation. This, both in the reduced CNI and in the standard CNI, is very similar, as you can see, which means that you could. And this have been the iBox algorithm, and every new invention has its own limitation. Its statistical significance as a criterion for the selection of variables may not be ideal one. You need to exclude some confounding factor, emerging predictors of the post-transplant risk factor as non-invasive biomarkers, or genetic factors might be missing, but it can be added, of course. And there are lack of information of adherence of the patient, which might, again, affect the outcome. So it is transforming the future application by the PTG group using the iBox in clinical development protocol, and you need to define realistic and feasible endpoints for upcoming clinical trials. The endpoints can be potential innovative combined parameters, histopathological endpoint, intragraft gene expression, or anti-HLA and DSA. The iBox score uses functional parameter, immunological parameter, histological parameter, and demographics parameters. These are 8 parameters that have been combined to be used in the algorithm in a computer model. And finally, it gives you excellent patient care, excellent patient monitoring, and strong medical decision-making may be helpful in choosing the proper drug for the proper patient in different clinical scenarios. And it can be generalizable, it is specific, its causality is high, there is accuracy and feasibility and transportability. I'm sorry for exceeding the time, and thanks for your patience.
Thank you very much, Dr. Ahmed, for this very updated vision. I had one question from the audience. It looks a little bit simple, but they want more explanation about what is the meaning of surrogate endpoint. I know it's difficult to do.
Well, surrogate endpoints is a point that you cannot say it is specifically causing this, but it is a marker that you would take along when you are going on. يعني let's say هي بنقول عليها بالضبط العلامات المصاحبة أو النقاط المصاحبة اللي ما أقدرش أقول إنها كوزاليتي، ما أقدرش أقول إن هي السبب، لكن هي مصاحبة للي بيحصل فينفع تمشي معايا في سكتي.
Okay, thank you very much. Let's now move to Professor Maya Hasaballah. Professor Maya Hasaballah is the president-elect of the society of our society, Egyptian Society of Nephrology and Transplantation, and she is having much effort in the registry for this society, and also much interest in some aspect of transplantation, especially trying to solve the problem that we don't have cadaveric transplantation yet in Egypt, and maybe we will go to the paired donation as a substitute. Professor May, please, you may start.
Thank you very much for the introduction. Professor Hani, can we get it from the start, please? Okay. Okay. Well, my talk today is going to be about the paired donation, which is, I think, is a very important subject and is badly needed in Egypt. So it's when recipients with incompatible donors, they swap the donor to receive a compatible kidney. This is called paired donation. And it is, of course, a form of living donor transplantation. So we're going to speak about the indications, the type, the history, the innovations, the KPD, and Egypt, and then I'm going to conclude. So the reasons for participating in kidney pair donation are ABO incompatibility, and you know that recipients with blood group O, they are disadvantaged in having a natural anti-B and anti-A, and also HLA incompatibility and sensitization of the patients, and of course due to previous transplantation or repeated blood transfusions or repeated pregnancies. And of course the level of sensitization, as evidenced by the calculated pan-reactive antibody, correlates with the difficulty with which the recipient is going to find a donor. And when it's more than 80%, it speaks about a long waiting time to avoid unaccepted HLA matches. So if you look here, the current US waiting list based on the Organ Procurement and Transplantation Network data as of January this year, you can see that the wait list has more than 124,000 patients on the wait list, and out of those we have more than 102 patients waiting for the kidney. Now, the other reason for participating in the KPD program is to improve the transplant quality and tissue compatibility. And like when you have a relatively young patient with an older donor and he wishes to have a matched young donors, or when you have an unsensitized patients with who have HLA mismatches, and the target is to increase their matching, with find donors with more matched antigens to share. So that's because antigen match matters. If you compare here patients, donors with 6 matches, they have a half-life of 41.4 years as compared to less matches, ranging between 22.6 to 26.5. And also because the donor age matters. If you compare donors 65 years and older, they have a graft survival of 29% as compared to younger age groups, ranging between 56 and 62%. So when the donor is not compatible, it's going to be this swap. The donor 1 is going to give recipient 2, and the donor 2 is going to give recipient 1, and this is called 2-paired exchange. It can also be 3-paired exchange. 4-pair chain. What we done in altruistic donor, this occurs an altruistic donor. This is an anonymous donor, non-direct. This is a donor who just wants to donate to anybody, is give this recipient, and then the donor to give to the other, so on and so forth, go on endlessly, except a donor is going to donate his kidney on a wait list. This is the chain. So this looks like as you can see, the extraordinary acts of kindness saved 140 lives. And actually it was done to start your vision. Okay. So for many years, the matching of the potential kidney recipient donor pairs was done through the local hospital or partnering with the area hospital. But actually, the idea of pair donation was first started in South Korea, then it went on to the Switzerland in the year 1999, and then the United States in the year 2000, and then in the Netherlands 2003, and in Canada 2005. In the US, the opt-in has started paired donation, kidney donation chains programs occurring all through the US, and this was done through the federal government organized registry by UNIS or by hospital-based registries such as the Johns Hopkins and the Alliance of Pair Donation, the Methodist, and also we have the National Kidney Registry. And then it went to spread all through the world. And you can see the numbers are increasing over the years, still increasing. And if you look here, you can see that the growth of the pair donations has increased over the years to more than 200,000 on a yearly basis. And if you look at the red bars, this represents the National Kidney Registry, which contributes to the largest number of patients. Actually, it's the largest kidney paired exchange program in the world. So, of course, this requires the more areas you have and the more chances you have in optimizing your match and accommodating those patients who are difficult to match. And of course, this requires a software platform and a sophisticated algorithm. And I'm going to give you an example of the ALICE of paired donation, how it works. So the computer program first matches for the HLA, first for the ABO, and then it goes on for the virtual cross match after excluding the donors with the unacceptable HLA matches. And then the points are given based on the age difference on the number of B locus HLA and the DR locus HLA and the highest serologic pan-reactive antibody. And then you get bonus points based for those less than 18 years old. And if the recipient was a donor, was a kidney donor himself, and for CMV negative to CMV negative, and Epstein-Barr virus negative to EBV negative, and for zero antigen mismatch, and on the recipient's waiting time. There have been many innovations in kidney pair donations occurring, realizing how important this is and how to make things easier. And one of the most important innovations is the shipping of living donor kidneys. Now, before that, the donor used to travel all the way to the recipient city, and the operations performed in an unfamiliar hospital away from relatives and friends. But now the kidneys are shipped. The kidneys are shipped unattended on commercial flights with the GPS just to know the whereabouts of the kidney. So this has led to a marked increase in the donor pool and made things easier for the donors. It is now, this is the strategy that's going on now. And there's been evidence that the long cold ischemia time is no big deal. For instance, in this study here, more than 2,000 shipped living donor kidneys transplants, 4.1% were more than 65 years and 6% had a cold ischemia time of more than 16 hours. And actually, there were no significant associations between the delayed graft survival and the donor age or the cold ischemia time when you compare those with less than 16 hours and those with more than 16 hours. Well, the second innovation is the voucher, which really tackles the problem of when the donor and the recipient are incompatible in time. So we have the advanced donation and we have the banking. In the advanced donation, the donors could donate at a time most convenient to them, even if his recipient pair has not yet found a match, a suitable donor or scheduled for surgery. So this article was by Fleckner and colleagues, and then at that time, it was in the year 2015, 10 such donors facilitated 47 transplants, and thus far, 8 of their paired recipients have received a kidney between 2 weeks and 19 months. And the other thing is the banking, and the banking is when the donor is unable to proceed with the donation at the present time because his recipient does not yet need the kidney. Say, for instance, his creatinine is still 2, but then he is unlikely to be able to proceed in the future because of aging, because of expected mortality, or because of future events like work, travel, or pregnancy. So in this case, the paired exchange program is committed to give us his recipients a priority in the paired exchange program, so that he is going to receive the first kidney that will conclude this chain. This is the voucher donor. So he is going to act like an altruistic donor, and whenever and if ever his recipient will need a kidney, so he's going to receive the donor kidney that then will conclude this chain. Another innovations in laboratory and mathematical and logistical optimization. Well, actually, the laboratory innovations such as cryopreservation have increased. Have increased the convenience for donors, whereas improving the speed of the paired exchange programs. And well, actually, the success of the paired donation does not only hinge on the surgical procedures or the immunosuppressive medications, but it has to do with the improvement in the matching algorithms, the computer softwares, and the logistical optimization. An example of the logistical optimization is that the image of the anatomy of the kidney in the donor hospital can be viewed by the recipient's surgeon at any time, anywhere, with a click of the mouse. So this is a kind of real-time sharing of the images. Okay, so why is everybody doing that? Why is it so important? Well, actually, that's because living donor kidneys last longer. If you compare here the living donor kidneys in years compared to deceased donor kidney transplants, so living donor kidneys, they do last longer. And because the 10-year overall graft survival in preemptive transplantation is better than in those who have stayed on dialysis for 24 months and more. And that's why the results of the National Kidney Registry, if you compare it to the US living donors, if you compare it over the years, it's better because of the superior avoidance of antibodies, of HLA antibodies. And the outcomes are better in spite of harder cases like those with more cold ischemia time and those with more highly sensitized and hypersensitized patients and more retransplantations. Okay, so let's see what about the situation in Egypt. Of course, we are overpopulated, so we do have donors, but however, there is lack of awareness, and this is something which we have to work on. And also, it's easier to transport organs in Egypt. It's not like the continent, America. And we can start from where others ended, and we can start simple and on a small scale. And we can start the donations to be done at the same time simultaneously, so as to avoid the hazard of a donor declining transplantation when the other donor procedures is performed. So we have to put rigid rules for that. And the donor should be reimbursed for surgical procedures and travel expenses. So this calls for a national organization, and we have to have a high level of coordination between the hospitals and the national organizations. So this requires that allocation be done with both to be medically sound and ethically acceptable in terms of utility, of equity, and justice. So let's see what are the options for patients with unmatched donor. Well, so he can either discard transplantation, so forget about transplantation. So this means that it's going to remain on dialysis for the rest of his life. Or he can use deceased donor. And this means there's going to be a long wait list. And besides, we don't have deceased donor program in Egypt, in spite of the fact that we do have a law. Or he will go on for desensitization. And yes, desensitization has a survival benefit for kidney transplantation from HLA incompatible living donors. If you compare those patients with recipients of incompatible transplants as to those on the wait list or had a cadaveric transplant, as compared to those on the wait list only, you can see a survival benefit over 8 years. But then those patients will have to receive whatever regimen is going to be used for desensitization, whether it is going to be pre-transplant, immediately pre-transplant, or post-transplant. They're going to use expensive drugs like Thymo, IVIG, rituximab, plasma exchange, and others, of course. So therefore, it's going to be a big cost, and is going to be subjected to immunosuppressive medications. And still, we have the problem of antibody-mediated rejection, which is as high as 50% among recipients of HLA-incompatible grafts, which, if clinically silent, is associated with twice the risk of graft loss, and if associated with graft dysfunction, it is associated with a 6 times risk of graft loss. And this just tells you that desensitization rate is declining in the National Kidney Registry. It's going down in spite of the fact that the number of transplants are increasing. Well, what the last resort for these patients is to use another living donor. So this could be a kidney pair donation through a kidney pair donation program, or it could be a commercial donor. So when we don't have a kidney pair donation program, then we'll have to go on for the commercial donors. And unfortunately, it does exist in Egypt. Now, this is one of the very interesting articles that was published in the Egyptian Society of Nephrology and Transplant Journal on kidney pair donation program, a national solution against commercial transplantations. And it went with these suggestions to start a national kidney pair donation program framework in Egypt. And these were establishment of a national organization for KPD program, defining transplant centers participating in the program, setting up rules for donor allocation and matching, and standardization of laboratory imaging testing for the donors on a national basis, and setting up donor follow-up clinics with full insurance in a consistent manner for donor safety and as a support for their donation, and acquiring sufficient financial support for the program. So in conclusion, with kidney pair donation is a remarkable innovation in and of itself. KPD programs has the following advantages: and increases the number of kidneys available for transplantation, allowing the most incompatible pairs find a match and get transplanted, avoidance of the risk and costs of desensitization strategies designed to remove anti-donor antibodies, decrease the waiting time on national transplant lists, provision of living donor grafts, which are usually superior to cadaveric ones, and finally, put an end to commercial transplantations. And also by including ABO-HLA compatible pairs, it increases the chance of finding a great HLA match and younger donors, which is correlated with more kidney life years. And it increases the donor pool for difficult to match pairs. So KPD is the best option for living donation and should be considered for all potential living donors. And it's badly needed in Egypt, especially in the absence of deceased transplantation, the non-familiarity with the ABO incompatible transplantation, and the high cost of desensitization and the existing commercial transplantation. And thank you very much.
Thank you very, very much, Professor May, for this very elegant presentation. And we hope that in the near future, we find this pair donation program coming as a reality. And also, we hope that the cadaveric program could be a little bit moved forward. Thank you very, very much. Now we will shift to Professor Maria Paula Gomez. Professor Maria, we are quite happy to have you with us today. We know that the Spanish model of transplantation is practically the best in the world, and you can transplant now around 50% of your end-stage renal disease or CKD5 patients. So you have a very active program. And of course, we will learn a lot from your talk about how you are doing this magic result, surpassing the United States and surpassing many other European countries. Professor Maria is the Executive Director of the Donation and Transplantation Institute, a DTI Foundation in Barcelona. She is the Medical Coordinator of the International Registry for Organ Donation and Transplantation, and she is the Counselor of the International Society for Organ Donation and Procurement, ISODP. So we are all eager to hear from you the overview of organ donation models worldwide and the impact of the educational program. We heard from Dr. May just that the education program is very important, and unfortunately we don't have much education program for paired donation in Egypt. So you will give us hints about how to implement this education program. Thank you.
Good evening, and thank you very much for inviting me to participate in this very interesting discussion. So I will share my screen. Can you see my screen?
Yes.
Okay, so tonight I would like to talk about to give an overview of the organ donation models worldwide, and also address about the importance of education or educational program, training programs in organ donation. Just to remember from the Global Observatory on Donation and Transplantation, every year have been performed around 100,000 organ transplant around the world. But we know that this is less, or about the 10% of the global needs. So if we analyze this country by country and only regarding kidney transplantation, this is a figure from the IRODAT registry, and it's a worldwide kidney transplant from deceased donor in 2019. So we can see here the rate of Spain with 72 kidney transplant from deceased donor per million of population, followed by France, United States, Finland, Portugal with 42.8 kidney transplant per million of population. If we talk about living donation, kidney transplant from living donors, so the picture is a little bit different. We can observe Turkey in the first place with 36 kidney transplant per million of population, kidney transplant from living donor, following by Saudi Arabia with 29, and Netherlands with 28.9 kidney transplant from living donor. All of these figures are openly available in IRODAT registry. The website is irodat.org, and you can find not only kidney transplant, you also can find heart, liver, lung, and all other organs for transplantation. So why is this? Why we have, I will go back to the previous one, why we have these countries, no, Spain, France, Finland, Czech Republic, Portugal, Uruguay, in the top for kidney transplantation in general and from deceased donor? Well, it's basically because this is the figure of the actual disease organ donation rate worldwide. And then we can find again Spain, Croatia, Portugal, France, USA, Belgium with the highest donation rate. No, for example, Croatia with 34 in 2019, Croatia with 34 donors per million of population, or Portugal with 33 donors per million of population, and as we know, Spain near to 50 donors per million of population last year. So if we just concentrate in MENA, Middle East and North Africa region, or mainly Middle East, so for 2018, we have Iran with 11 donors per million of population, Israel with 13, Turkey with 7, Saudi with 3 donors per million of population, and Emirates start to develop their disease donation program. So there is still a lot of room for improvement. And regarding living, as I mentioned before, Turkey is the highest in the world with 52 living donor per million of population. And then we know, this is very well known, with our organs there is no transplant, and then the World Health Organization is encourage the countries to implement or to enhance their donation activity, their disease donation activity, and implement the self-sufficiency. So develop a group of strategies in order to create disease organ donation programs for transplant. What are the different transplant procurement models or disease organ donation systems? So in the past, that happened was a hospital with a transplant team. They have the responsibility to obtain organs for transplant. Right now, we can identify 2 different types of model. The American model, where there is an organ procurement organization, which is an independent office outside of the hospital. And then the Spanish model or European model that we call leading practice in organ donation, where inside of the hospital there is the transplant team or not. It could be only a donor hospital, and there are a TPM office or something that we call a hospital-based organ procurement unit. So what is the key of this best practice for organ donation, and that is happening not only in Spain. I have to stress that this is also happening in other countries, not only in Europe, and also countries from Asia and some from Middle East start to implement this. The first thing is the in-hospital organ procurement unit. So organ donation is a hospital service. Disease organ donation should be seen as a hospital service with an in-hospital organ procurement unit. Transplant procurement managers, TPMs, this is healthcare professional specialists, specialized in this matter, in this subject. The need of a networking, so a national system with a national and regional transplant offices to provide a transparency among other subjects for organ allocation. Training of healthcare professional, as we know, as we mentioned, this is we need a specialist in the subject, so we need to train them. We need that they gain knowledge in the field. Budget, this is not voluntary role regarding transplant procurement managers. Then the system will be needed to allocate a budget to offer to them a proper job and a career pathway for their development. And of course, budget not only for this, budget for the administration and the management of the entire system. And of course, a good communication with the society, education and raise awareness with the entire society. Organ donation is a hospital process. So this is, I guess, majority of us, we are familiar with this process, but this is to mention that as it's a hospital process, all the strategies must be implemented inside of a hospital or inside of a healthcare system. No, this is a very well-known process, starting for donor detection, following for the death declaration, donor and organ assessment of viability, donor maintenance, donation consent, recovery, distribution, and transplantation. And then starting for one of the main steps, which is the detection or the identification of these possible donors, I like to bring this from UK, which is they performed a task force in 2012 in order to provide some recommendation how to improve their organ donation rate. And then that they identify is that organ donation should be seen as a normal part of the end-of-life care, not only in Spain, everywhere. So the invitation is for the hospitals in Egypt that every patient who is dying or every patient who is considered with poor prognosis or futility of the treatment, organ donation should be included in the conversation. What happened with the TPMs? What are the bases of the system? The people, no, the doctors and the nurses that we call or donor coordinator or transplant coordinator or transplant procurement managers. But basically they are full-time, or in some hospital they are part-time dedicated to this process that we saw before. No, so they are coming from critical care units, and I am referring to not only intensive care unit, also emergency departments, neurosurgical units, and they are mainly physician or senior nurses. This is from our National Transplant Organization, and I bring this is just to show you the number of teams that we have. This number is referring regarding the number of TPMs that we have in our country dedicated to this matter. So you can see how the number have been growing over the time. And this is just some photos of TPMs around the world. So all of those are intensive care doctors or senior nurses who have been trained about the disease organ donation process in India, in Emirates, in Iran, but also from China or from Croatia, Portugal, France, and so on. And then what is the role of these TPMs? As I mentioned, they have to, the importance of the professionalization of procurement process. They are specialists. They are specialists in disease organ donation for transplant. And they have to do the detection, they have to assist and support the diagnosis of death. Don't do the diagnosis. The diagnosis has to be performed by the treating doctor plus the neurologist or neurosurgeon. But TPMs will help and assist with the diagnosis of brain death. The donor assessment, donor maintenance, and of course the family approach. And then this is a matter also about teamwork. So will be needed these transplant coordinators that sometimes they are social workers or they are nurses or they are coming from admin department, and they also will support the process with the logistic, with the allocation logistic, or supporting the family, the donor family, or with the hospital awareness. What else? The in-hospital organ procurement unit. So I bring these photos is because this one here in the left is the hospital clinic in Barcelona. We have our organ procurement unit. This one is from the Hospital 12 de Octubre in Madrid. So as you can see, they are doctors and nurses who are dedicated to this role, no? And now I bring these two pictures because this is from Mafraq Hospital in Emirates, that they create the first organ donation unit in their country. And we have here in India, in Kerala, in the south, that also Dr. Murali, who is this guy here in the picture, he is intensive care doctor, and together with his team, they create the first organ donation unit or organ procurement unit in their hospital. And what are the functions? The functions are clinical, of course. They have to go to the entire disease organ donation process, the one that I showed at the beginning, detection, validation, brain death confirmation, and so on. But they also have to do education. So they are the responsible to build the culture in the hospital regarding organ donation, a whole culture across the hospital. They have to do some research in order to improve the quality of the organs that they are offering. And then, of course, they have to implement quality programs in organ donation in order to improve their performance. And finally, all the management of the system inside of their hospital. What happened about the training? I bring this study. This is from Transplant International and published in 2010, but I like it because this is from 11 countries and it was performed during 2 years. Then we have here Australia, Belgium, Croatia, Finland, France, Italy, Norway, and that they did was a hospital attitude survey among the critical care staff. And that they found was that the critical care staff attitude, confidence level, and educational needs correlate with country's donation rate. So as a higher the positive attitude or the higher the knowledge of the critical care staff regarding disease organ donation, higher the donation rate. What else? This is another study. This is the European Training Program on Organ Donation. It was an European project performed in European countries, and then it was identified 25 target areas from 16 countries. 25 target areas were some hospitals, donor and transplant hospital from 16 European countries. And then they train these people. That they did was train the trainers, and later on the new trained people, they become professor and went back to their hospitals and they retrained their own staff. And that was observed was the number of utilized donor identified increase when we compare the previous period before the study and the period during the study. And also the number of organs recovered increase. And this increase this improvement was observed in 16 of the target areas. So this is the first TPM Transplant Procurement Management course in 1991. This is a course that is happening in Spain every year. Our ICU doctors, our critical staff, healthcare professional from critical care areas attend this course, and many others that have been happening in the country every year. Happen twice, one in February and the other in October. The next one is this one, the Transplant Procurement Procurement Advanced International Training course, which is happening completely online due to the current situation. And there is not only training in disease organ donation, also there is tissue banking, there is in organ transplantation, and there is a postgraduate diploma in management and in quality. As I mentioned before, the aim is to professionalize the doctors or this matter, and then there is the possibility to fulfill or to achieve a master degree in donation and transplantation. So far, we have 17,000 TPMs around the world from 100 countries, according to the different modalities, face-to-face, blended, and in the international master degree. And then these figures is the effect of the training in the donation rate. So the blue bars is about the number of people trained in the countries across the years. And the blue line, is the donation rate. So you can see here Croatia, Portugal, France, and Italy, how as much as doctors and nurses officially trained in organ donation, highest the donation rate. In the opposite way, because we know that sometimes we say, well, we have to do donor card, we have to include organ donation in driver licensing, we have to do mass media campaign or go to the schools. So it doesn't work. In simple and in summary, it doesn't work. This is a study from the Eurobarometer in Europe that they measure the willingness of the population to donate. So they went to the street and surveyed the people in the street from these different European countries, asking them their willingness to donate. And then we make a correlation between the willingness to donate and the donors per million of population. And then we can see here, for example, how this one, which is Sweden, had a very high in the population, a very high percentage of willing to donate. Near 80% of the population say, yes, we want to donate. But when you make the correlation with the number of donors, they were at this time in 15 donors per million of population. This data is from a few years back. So in opposite way, here in Spain, you can see how the willingness to donate of the population was near to 50%. And if you survey today, between 50 to 60% of the population in the street, we will donate their organs. But the actual donation rate, we know that is very high. So there is not a correlation between the willingness or the awareness or the level of awareness of the population in organ donation and the donation rates. What else? Regarding our national system, so Spain is divided in 3 levels. We have a national level within our National Transplant Organization, who belongs to the Minister of Health. We have regional office in each of our states or in each of our communities. And then we have hospital units, as I mentioned before. And we have transplant hospital registered, officially registered as a transplant hospital. No one who is not registered can perform a transplant in the country. And we have also donor hospital registered. We have organ allocation rules that basically we divide in geographic criteria and with clinical criteria. The clinical criteria, we have an emergency statute for the distribution of the organs, plus other clinical criteria according to each organ. And the geographic status is according to the procurement center. So the hospital will have the hospital where the donor is will have the priority to allocate their organs according to clinical criteria. So if the hospital is not able to allocate the organs, then it will be distributed to the city or to the region, or we divide the countries in zone, in all the Spain, and even we offered some organs to the rest of Europe. And regarding transparency, I bring this image here is because the criteria, the organ allocation criteria in Spain are available online. So anyone can come to the website and have a look or understand what are the allocation criteria for the different organs. Quality program in organ donation, important to get data, registry, transparency, get data, and audit the performance of the hospital, provide feedback, and help the hospitals to improve. So we developed, based on the organ donation European quality system, we developed this software, this tool that is called Quorum, where we measure different key quality indicators, the indicators based on structure, indicators for process indicator, and also outcomes indicators. And recently we applied this tool in Saudi Arabia, and this is the figure that I bring here because it was possible to increase the number of potential donors detected. Sorry, I move to the next one. It was possible. This tool was applied in 4 hospitals in Saudi Arabia, and then comparing 2017 versus 2018, it was possible to increase the number of possible donor identified, the potential donor identified, and then the rest of the pathway: eligible, consented, and actual donation. So, in summary, what is happening in Spain? This figure is the disease organ donation according to the type of donor, DVD and DCD. I have also to mention that in 2012, it was introduced officially DCD control donors in Spain. And of course, we have been having DCD and control from very beginning. And then here that I want to correlate is when in the time was introduced in the system the different strategies, So since the very beginning in 1989, the first thing was the donor network and the donor coordinator profile. What is this? The TPM. So it was the first anesthesiologists, intensivists inside of the hospital, together with some transplant physician, of course, nephrologists, that they take the leadership. They took the leadership to create the system. Later on, and the cooperation with the intensive care physician. Then in 1990, the National Transplant Organization was established. And since the very beginning till now, because it's never stopped across the years, was the professional training. As I mentioned to you, every year in Spain, the intensive care physician have been trained in disease organ donation. And in Spain also is mandatory. And I have to say that not only in Spain, there are many other countries who are doing the same. It's mandatory for the doctors who specialize as an anesthesiologist or intensive care doctor in their career is mandatory to attend a training regarding disease organ donation for transplant. So later on, in 1990, we initiate our quality assurance program in organ donation, and then for the DCD, donor after circulatory death, the cooperation with emergency care and the other groups. And then, well, this is my message for today. Thank you very much.
Thank you very, very much. Very elegant and informative presentation, Professor Maria. And of course, we have many questions for you from the audience. One of them is that in our ICU in Egypt, we don't find the cooperation from the ICU doctors. And you are mentioning in your talk that the ICU training is mandatory to be trained for for this TPM program. So how can we solve this? Because I think this is one of the obstacles for our cadaveric transplantation, that the ICU doctors themselves are not so convinced.
Yeah, I think that it's very important to involve the intensive care society or the academic societies of the country, involving them to lead these training programs as well and to be part of these training programs. And the important to identify some champions, intensive care doctors that will become the champions for organ donation, and then they will be fully trained, national and international, in order to come back to the country and then spread the information and the knowledge. This is, sorry to say that, but it should be like a virus. You have to put a virus in an intensivist, and then this intensivist with that virus has to spread to the rest of intensivists. But it should be intensivist to intensivist or anesthesiologist to anesthesiologist. Will be very difficult for a nephrologist or a transplant physician convince or infect an intensivist. You need to infect that intensivist with another intensivist from Spain or any other country. Sorry to say that now in COVID time.
It's very practical what you are saying. Another question, actually, it was for Dr. Amaya and for you also. How can what is the legal aspect if one of the pair is in paired donation is going fine and the other is not? I mean, this will be in the mind of the pair who doesn't go well the transplant. So in the Egyptian mind, do you think that if one of the paired donors does not go well, this will hurt the program, or we can proceed further? Actually, it's for Dr. Amaya, and also we want your comment on it, Dr. Amaya. الفويس دكتورة ماي الفويس صوت
The donor is, can you hear me now? Can you hear me?
Okay.
The recipient donor pairs are informed of all the possibilities that can occur post-transplants. So they are informed and they give their consent to the possibilities that can happen after the operation. Well, in the States, I know that those patients who do not do well early in the transplant, they give them a priority in a pair donation program to receive a kidney from a chain. So they're given a priority. That's how to try to tackle. But
solve the problem. I mean, he gets another chance.
Yes. They have some rules that when the kidney is lost in time early in the transplant, they give them a priority in the pair donation program to receive a kidney from another donor. But you have to put rules for everything, of course. But things like that could happen. Of course, you're not sure, yani. You don't know what's going to happen after the operation. It's all in God's hands.
Yes. Dr. Maria, do you have any comment?
Well, I'm not quite familiar with the kidney exchange program. There is kidney exchange program also in Spain. And so far, we haven't experienced any big issue with the program in the country. No, but I'm not the best person to explain you about that.
Thank you very much. So now we will shift to the Professor Magdi Sharqawi. Professor Magdi Sharqawi, a professor of medicine and nephrology in Ain Shams University, and he is a leader in the field of dialysis, and he has his next month at the 1st of October a big event with the Hemodialysis International Society, but also Professor Magdi is quite interested in transplantation, and he is heading the transplant program in Nasser Institute, and he will be speaking today about the diabetes with the transplantation and the anti-diabetic medication in post-renal transplant. Professor Magdi Sharqawi, please.
Thank you very much, Professor Hani, for a very kind introduction, and thank you for inviting me to this great event. I welcome all the speakers, and I'm going to speak today about how to manage diabetes in post-renal transplant world. As mentioned, and as we know, organ transplantation is becoming widely popular. The most organ to be transplanted is the kidney, of course, and the incidence of diabetes mellitus either before or after transplantation is the highest instance in kidney transplantation, followed by heart and lung transplantation. So actually, we face a lot of patients with diabetes after kidney transplantation. It's not just new onset diabetes, but it's also diabetes. And although diabetics represent the major risk for developing end-stage kidney disease, in this Spanish study, and Professor Maria is with us today, 3,300 patients only 4.6% of them transplanted are actually diabetic, and then 7.4% develop post-transplant diabetes. Also, we have to know that glucose metabolism after renal transplantation is totally different than a non-transplant patient, because a diabetic and non-diabetic patient will develop decreased insulin secretion and decreased insulin sensitivity. Part of this problem is due to the use of CNI and mTOR inhibitor, which directly inhibit insulin secretion from the pancreas. Usually, post-transplant diabetes occur in the first year after transplantation. It's almost affecting 15 to 30% of post-transplant patients, and then it will level. And this more recent study showing the same, it's highest within the first 6 months, and then it levels afterward. We may have a risk score, as Dr. Ahmed said in the first presentation, to detect which patient who may develop NODAT or post-transplant diabetes. Because nowadays, there are 2 trials to prevent diabetes after transplantation. And this risk score include body mass index of the recipient, the age of the recipient, his fasting blood sugar first post-operative day. If it is more than 159, it's at high risk, and fasting blood sugar in the 5th day, if it is above 122, he is at highest risk, and home IR also increase the risk for developing diabetes. It's very important to control blood sugar, either in those who are diabetics and in those who will develop NODAT. Why? Because diabetes will decrease graft function and will increase graft survival by development of diabetic nephropathy, hypertension, and it may affect the immunosuppressant doses. And also it affects patient survival by increased incidence of infections and increased risk of sepsis and cardiovascular disease. And it increases the cardiovascular disease morbidity and mortality in these patients. And the actual survival of diabetic patient, those who develop post-transplant diabetes are less than who don't develop post-transplant diabetes. And in diabetic patients who already transplanted with diabetes have the worst outcome of those than those who have new onset diabetes or those with no diabetes. And this is very important because diabetic nephropathy or patient with diabetes represent some part of our transplant community. We have to take care that diabetes, when we transplant a diabetic patient, there is no increased incidence of rejection, but there is decreased graft survival and decreased patient survival if there is poor diabetic control. So when we transplant a diabetic patient, we have to be careful to strictly control his diabetes post-transplantation. And then come to the main topic of my presentation, how to prescribe anti-diabetic medication in either diabetic patient or those who will develop diabetes post-transplant. First, we all know that there are several mechanisms by which these drugs are acting. Some of them increase glucose entry into fat cells and muscles. Some increase pancreatic insulin release. And we have nowadays drugs that act through the kidneys, and some of them through the liver, and also incretins through the intestine. The international guideline, this is a 2020 American Diabetes Association guideline. It states that in patients with CKD, the first drug to be used after metformin and after lifestyle is sodium glucose transport inhibitor or GLP-1. Also, we can use drugs that reduces hypoglycemia, which is also common in patients with diabetes in CKD population. And we should consider a transplant patient as having some sort of CKD. And this includes the DDB4 group, the GLP group, and the long-acting insulin. And then we consider other drugs. But this, together with the KDIGO guideline, which is published this year, that also stated lifestyle, metformin, sodium glucose, GLP-1, and DDB4, but they excluded NODAT from this guideline. They are not included in the guideline, so we don't have a guideline for patient post-transplant diabetes. That's why we need to consider how to select this anti-diabetic medication. First, we have to be assured of the efficacy of the drug, the safety, and drug-drug interaction, and finally, the cost. The efficacy of most recent anti-diabetic drug is good, and they can all be used in control of diabetes, especially if we want to strictly control this patient. We have to know the side effects, especially hypoglycemia, but also the drug-drug interaction of this medication is very important, because in this study, it showed that many drugs have drug-drug interaction. Metformin was not recorded to have interaction, but sulfonylurea, which are commonly used, have drug-drug interaction with cyclosporin. And also bioglitzone have drug interaction with CNIs. Sitagliptin and vildagliptin, which are DDP4s, also have some effect on cyclosporin and Prograf. And other drugs are not yet studied. So we need further study to know the side effect. Maybe the most famous side effect is with sulfonylurea, the interaction with sulfonylurea and cyclosporin and sirolimus. Ribaglinide also with cyclosporin and sirolimus, and saxagliptin and sitagliptin, the DDP4, with sirolimus. So it seems that sirolimus has the highest interaction with most anti-diabetic medication. Let us review drug by drug or group by group. Metformin is the most commonly prescribed anti-diabetic medication worldwide. And in this registry, from 2001 and 2012, 4,600 patients post-transplant receiving metformin. And it showed that it's not associated with worse patient or allograft survival, although many physicians avoid metformin in post-transplant diabetes. In another many review also stated that metformin is safe and tolerable in patients with post-transplant diabetes. And in this very nice study published in Clinical Transplantation, 14,000 patients prescribed medication for type 2 diabetes, 4.7% of them are taking metformin, and it was noticed that many of them are taking a full dose or reduced dose of metformin according to the GFR, and it was associated, metformin prescription was associated with the least mortality in such patients, very significant difference from other medication, and also it has a very good effect on acute graft rejection, in this censored graft failure or all-cause graft failure. So metformin should be considered as one of the very nice drugs in this category. This is a Transdiab study, also with metformin, 78 patients, and again, it stated that metformin post-transplant patients appeared feasible and safe. Sulfonylurea also are very commonly and widely used in post-transplant patients, but there is little evidence of safety and efficacy. And as I mentioned, they have interaction with cyclosporin and CNIs. So we should use them carefully, and also there is risk of hypoglycemia. Ribaglinide have lesser hypoglycemia than sulfonylurea, and also there are some studies showing it has a modest effect in post-transplant diabetes. And actually, we have no safety profile of them. What about bioglitzone? Bioglitzone are anti-inflammatory group of anti-diabetic medication. They increase insulin sensitivity and decrease the need for insulin in such patients, in a post-transplant patient, and they are well in controlling hemoglobin A1C. And they have some interaction with Prograf, but not that significant. It decreases the level, but not to a significant way. And it was noticed from the same study, comparing the anti-diabetic medication, it has reduced acute rejection in the first few months of transplantation because it has anti-inflammatory effect, and it also reduces the CRP and interleukin-18. So it might be used in patients with post-transplant diabetes. They interact with sirolimus. Again, we should notice that they have interaction with sirolimus. What about insulin? Insulin is the most widely prescribed anti-diabetic medication worldwide, and actually it is one of the best medication for post-transplant diabetes, but there is few studies studied insulin safety and efficacy in patients with diabetes. It is used, it is most commonly used. We all use it for post-transplant diabetes, but it's not well studied. It has no significant interaction with anti-rejection drug, so it can be used. Studies have studied that using basal insulin therapy early after transplantation have successfully reduced the need for post-transplant anti-diabetic medication in the future. It controlled the blood sugar early, and it decreased the need for later on to be continued on antibiotic medication. This is the same with NPH insulin, also resulted in decrease the need of antibiotic medication later on. Or sometime it reverses the incidence of post-transplant diabetes. The relatively newer medication, which include incretin, GLP-1, and DDP-4, we know that DDP-4 have anti-inflammatory effect, reducing TGF-beta, reducing microRNA expression, and they are actually studied in post-transplant diabetes, but the studies are small in number and short in duration. This is a study evaluating DDP-4, and it showed it has better control of diabetes than sulfonylurea, with less hypoglycemia, and safer than hypoglycemia, especially regarding hypoglycemia, safer than sulfonylurea. This is a study also of vildagliptin in post-transplant diabetes, is the randomized controlled trial showing very effective drug on fasting, postprandial, as well as in A1C, and it appears safe on the kidney with no incidence of rejection and no interaction with the anti-diabetic or anti-rejection medication. And this is a very challenging trial. We are waiting for its result. It should be published this year in December. This is the PRODICT study to prevent new onset diabetes after renal transplantation by giving the patient vildagliptin at the start of at early post-transplant period, and for 2 months. If this succeeded, it will change how we look into post-transplant diabetes, and we may be able to prevent post-transplant diabetes, especially in those at higher risk of developing this disease. This is also another study on sitagliptin, another DDP-4, showing the same very good effect on hemoglobin A1C and in fasting and postprandial blood sugar. And also, the drug was well correlated with no side effect regarding the graft or the kidney function. We have many other studies on sitagliptin and saxagliptin, but it's not that good trial. GLP-1, injectable GLP-1, liraglutide, have shown in non-transplant patient very good kidney beneficial effect, reducing proteinuria, and it was tried in 24 renal transplant patients with post-transplant diabetes, and it showed very good effect by reducing insulin, by increasing insulin secretion and reducing glucagon secretion, and thus controlling blood sugar. Another study just on 7 renal transplant patients also showed it's not only control glycemic control, but it reduces body weight, and the graft function was significantly improved, and there was no significant change in protein create ratio. This is another study on GLP-1 inhibitor, and also showing it is safe and effective in renal transplant. This is a study on dulaglutide, which is once weekly injectable GLP-1, 60 patients followed for 24 months. Again, it showed very good effect on A1C and body weight, and the effect on the graft was good, and GFR actually slightly but not significantly improved, and this will provide that this group of drug may be beneficial, and it should be tried in patients with post-renal transplant diabetes. And this study persisted for 2 years, so it might be wise to use them. Then the sodium glucose transport inhibitor. We know now that nephrologists they like this group because it protects the kidney. It's approved by ADA until CKD GFR 30 in 2016, and the ADA picked them as the first choice in CKD in 2019, and the KDIGO guideline 2020 also included them at the first line in DKD, but again, not in NODAT. There is very good evidence from the widely published studies, the Credence, the EMPEREC, the Canvas, the DECLARE, that they have very beneficial effect on GFR and on proteinuria. And as I mentioned, the KDIGO guideline included them at first line treatment with metformin, but not in no diet. And the studies on them, again, a few patients. This is a study on 10 patients using canagliflozin, and the drug was well tolerated and have similar therapeutic efficacy compared with non-transplant patients. Another study on canagliflozin, 24 stable kidney transplant patients. There is a reduction of blood sugar, body weight, and blood pressure, and there is no hypoglycemia, and there is no side effect, significant side effect in this drug. Imbecliflozin, this is a study on 22 patients in post-heart transplantation, and the drug was safe and showed no significant interaction with anti-rejection medication. This is another study by Imbecliflozin on 44 renal transplant patients, and again, the drug was safe in renal transplant patients with post-transplant diabetes. Another study, again, 44 renal transplant patients, Imbecliflozin showed effective reduction of fasting postprandial and A1C, and the effect of Imbecliflozin was dependent on the GFR. The higher the GFR, the better the outcome with Imbecliflozin. And the safety of this study, there is significant weight reduction, arterial stiffness reduced, pulse wave velocity decreased, and no significant difference kidney function between the placebo and Imbecliflozin group. And there is no rejection episodes. The drug was well tolerated, no serious side effect. One patient only developed urosepsis, and there is significant increase in hemoglobin and hematocrit as expected with this class of medication. There was significant reduction of uric acid, and concomitant reduction in body weight was seen, and patient adherence was almost 100% in this group of the drug. What about immunosuppressive drug safety in this study? Dose adjustment was not different than in other medications. Only 4 patients reduced their calcineurin inhibitors, and there was no difference in trough level of immunosuppressive drugs. So the conclusion that this sodium glucose transport inhibitor, this is another case series in 10 patients showing the same effect, and all patients have a stable kidney function, and acute kidney injury was recorded in 0.16 per patient per year, which is very low. And this drug actually was reported to be safe in this patient post-transplant diabetes. But we have to remember that these studies are small numbers and short period. Finally, maybe the best solution is kidney and pancreas transplantation. This is a study showing 28 subjects who was type 1 diabetes who received kidney and islet transplantation, and it showed very good effect. 10-year markedly improved metabolic control without anti-diabetic medication. So this might be the solution for post-transplant diabetes. Having said that, individualization is very important, because as I mentioned in the study, in the presentation, most of the studies, even with insulin, sulfonylurea, DDP4, sodium glucose, metformin, are small studies and not case-controlled studies. That's why in the Cochrane publication 2017, they concluded from studying several studies in this subject that the evidence concerning the efficacy and safety of glucose-lowering agent in treating pre-existing and new onset diabetes and kidney transplant is limited. And existing studies examine more intensive versus less intensive insulin therapy and the use of DDP4 inhibitors and Bioglitzone. This is the field of their research. And there is limited evidence for safety and use of contemporary glucose-lowering agent for kidney transplant recipient with diabetes. And we need, of course, more randomized controlled trial investigating different insulin regimens. So individualization of each patient, what he's using before transplant and what's the best of him according to his weight and according to other comorbidity. So to conclude, Mr. Chairman, diabetic patients are only 4 to 18% of all renal transplant patients. The studies have small numbers of patients and for short durations, and there is no randomized control trial. Most patient concerns are not regarding their diabetes control, and this is a very bad issue. Patients are concerned about their kidney function, their rejection, their trough level, but not for the diabetic control level. And there is no consensus or guideline yet for anti-diabetic medication in post-transplant patients, and there may be numerous interaction between immunosuppressive medication that we don't know, and we need to know to safely prescribe them in our patients. And thank you very much.
Thank you very much, Professor Magdi, for very elaborate and important talk about the post-transplant diabetes. I have one question regarding the long-term prognosis of those diabetic patients. What is the percentage of those who are totally cured after minimizing the doses of immunosuppression with time? How many need to continue on anti-diabetic treatment, and how many are cured, percentage?
Of course, this issue was not studied. Of course, there is no randomized trial to prove that this patient might stop their anti-diabetic medication. But we know that from practice, after the first 3 months and after minimization of immunosuppressive therapy, many diabetic patients need less anti-diabetic medication, and they may be controlled on 1 or 2 drugs only. And if we strictly control their blood sugar, the recurrence of diabetic nephropathy might occur very late, and it will not affect their graft. But we need to advise of early and strict diabetic control, and we have to anticipate, because sometimes the patient come after the first visit after transplantation with blood sugar 500. We haven't expected that. We should expect that. We have to anticipate the incidence of diabetes.
Thank you very much. Now let's move to Professor Hussein Shaisha, فارس الeducation أو طبعا Professor Hussein Shaisha is a professor of medicine and nephrology in Mansoura University and in the Urology and Nephrology Center of Mansoura. And he is very, very active in delivering continuous medical education, not only for Egypt, but also for Africa and the Middle East, to the amount that he published on the YouTube more than 250 presentation since the start of this year 2020, especially in the COVID era. And maybe almost daily we have one webinar or seminar issued or directed by Professor Hussein Shaisha. So we are pleased to have him sharing in this important transforming transplantation meeting. And we will hear about immunosuppression in renal transplantation, critical issues from Professor Hussein. Please.
Thank you very much, Professor Hani. You are the boss who directs us toward the improving education. You and Professor May and Professor Magdi and all my colleagues, without your efforts, it is impossible to have anything. So today I'm the last speaker, and all of you are exhausted, but I'm going to stick to the time because it is very challenging to speak after all these prestigious professors speaking about the important and critical issue in transplantation. To speak about immune suppression, it is very challenging because we can speak about immune suppression for not 20 minutes, 20 days, and we cannot stop because this is our job. But I'm going to hit these points. One slide for introduction, then a couple of slides about tacrolimus, the issue of biomarkers in immune suppression and the precision medicine, and then the major part of the presentation will be COVID-19 and kidney transplantation. To start with, this is the state of immune suppression. Cyclosporin is vanishing and is replaced almost by tacrolimus in the majority of renal transplant recipients. The same what happened with azathioprine is replaced by mycophenolate, either mycophenolate mofetil or mycophenolate sodium. With a special situation, in a special exception pregnancy, yes, we use azathioprine, but the majority of transplant patients are maintained on mycophenolate. The use of mTOR inhibitors, this is steroid use in adult and pediatric and kidney transplantation. 2/3 of transplant patients are maintained on steroid therapy, and this is in the pediatric. Let us go to the tacrolimus, and this is one of the important messages to start with. We have 3 types of tacrolimus. We have immediate release tacrolimus, known as Procurement, and we have 2 types of sustained release, Advagraf and the Inversus. So in Spain, for example, there are currently 3 available formulations of tacrolimus. Immediate release, that is given twice daily, and prolonged release, which is Advagraf, and lastly, multi-dose, that is extended release with improved pharmacokinetic form of tacrolimus. And this multi-dose technology, which improves the solubility of tacrolimus, and thereby its bioavailability by dispersing tacrolimus in polymeric matrix, the result is progressive release of the drug to the distal part of large intestine, and this is away from cytochrome system. This is why the curve, pharmacokinetic curve of multi-dose is superior to Advagraf. And this is a very nice study. Here, the patients were shifted from Procurement, which is immediate release, to Inversus, or Advagraf to the Inversus, and you see here concentration to the dose is improved significantly by changing from Procurement or Advagraf to the Inversus. So bioavailability of Inversus is superior, and even the problem with Advagraf is that we increase the dose when we shift from immediate release is not here, because even we may reduce the dose of Procurement. One of the important messages when we deal with tacrolimus is the variability. We have inter-patient variability and intra-patient variability. So we should follow the drug level every visit. And then if there is variability and the patient is not in the therapeutic range in less than 40% or more than 40%, the higher the percentage of patients outside the range, the poorer the outcome, especially if we are shifted to the low side, and the variability always to the low side. This means that we will have de novo donor-specific antibodies and rejection. So we don't like variability. So we should look at the level every time and then. This is one of the most important articles addressing inter and intra-patient variability. Intra-patient variability written in 15 pages and released this month. And the determinant of variability are food and drug interactions. If tacrolimus is taken with food, its bioavailability is reduced by 30%. This is why we educate the patient to take tacrolimus away from food. Suppose that the patient is not tolerating tacrolimus on empty stomach, then we should fix tacrolimus with food to avoid variability. A genetic factor, I think a genetic factor is not responsible about intra-patient, but explains inter-patient variability. Medication adherence, and this is a very important issue to be addressed and to educate the patient, and concomitant illness like diarrhea. If diarrhea with tacrolimus is completely different from diarrhea with other immunosuppressive drugs. Why? Because So I'm sorry for this interruption, but I ended the determinants of variability. So what are the clinical implications, the outcome, depending on the presence of variability? If we have variability to the low side, we can expect acute rejection, de novo DSA. But if we have high variability toward the high level, this means a toxicity and histological lesion. All these determinants can lead to graft loss. So we should do our best to avoid drug variability by delivering. One of the most important issues to be addressed is medication adherence, because medication non-adherence is one of the most common cause of variability, and it is reversible and it can be corrected. Regarding genetics, and this is a critical issue, because if we know the genetics, we can know the inter-patient variability. Why this patient receives 2 milligram and has therapeutic level, and the other 10 milligram and still is not in the therapeutic range because of genetic makeup. This is a study done on the African American, 65 Black and Caucasian post-renal transplant patient, assessing both cytochrome B system, genetic polymorphism, which is responsible about metabolism, and the ABCB1 polymorphism, which is responsible about absorption. It seems that if we have a look on both metabolism and absorption, it is the best for the drug level. What we have here at Mansoura, and this is the same date of the African American, 11 August, but in another journal, Frontiers in Pharmacology, where in the collaboration with Greece partners, this is the study in Egyptian patients. So in this study, we determined allelic frequency of cytochrome B3A5 star 3, and this is the non-expressor, in 76 renal transplant patients of Egyptian descent. Secondly, we evaluated the influence of this gene variant on tacrolimus doses required for these patients, as well as dose-adjusted tacrolimus trough concentration. What we have, this is the method, PCR with polymorphism using this restriction in the nuclease. And if you look here carefully, we have unique genotype. This is we have this genotype, unique genotype. If you look carefully, you will find here we have a star 3 homozygous non-expressor. This is the majority of our patient, 72% non-expressor, and 26% are heterozygous. And those who are homozygous expressor is minority. And this is a very strange data. It seems that in Egypt we are different from African countries, because African countries are more expressor. So this is that we have. What is the implication of this genotype? If you compare the dose, concentration per dose, and the concentration per dose, this is the first time and after a year. If the patient here, this is the non-expressor. In comparison to expressor, the expressor concentration to dose is less. This means that the expressor needs a larger dose. So it seems that if we know the genetic and the patient is non-expressor, we can use a dose, but if the patient is expressor, we can increase the dose preemptively. What about the biomarkers? And we have Professor Hannah Hafiz, who is very interested in the biomarkers. And this is one of the very recent, it's August, showing torquetinovirus. And the torquetinovirus is the virus, when it is measured in the serum, it can predict the immune suppressive state. It has no pathological consequences, but it's a reflection of immune suppression. So this is the study. This is a very nice study, because this is the cohort, the total cohort is 386, and the biopsy 37, and the infection cohort 274. And this is the data, because they did the TTV load on weekly basis in the first period of transplantation, and then monthly. So this is and they found the best value of TTV load is between million and 100 million cups per milliliter, because less than 1 million is reflecting under immune suppression, and the patient is at risk of rejection. And if it is above here, this means that the patient is over-suppressed and may be at risk of infection. And this is the editorial comment on this article. Torquetinovirus load as a surrogate marker for the net state of immune suppression, the beneficial side of virome. What is the strength of this study? It is observational, yes, this is a limitation, but here, how many measurements? 3,265 in a cohort of 386 patients. So this is a big cohort of patients up to date. Another important biomarkers, and the first time to hear about this DD donor-derived circulating free donor-derived DNA. The first time to hear about this biomarker was from Professor Hani since a couple of years when he presented some of the updates from the conference about the AlloSure testing for testing the donor-derived circulating free DNA. I am one of the big fans of this biomarker, but today I'm going to present negative data. So this is the use of plasma donor-derived cell-free DNA to monitor acute rejection after kidney transplantation, and this is from 107 kidney transplant recipient, and there is the test on day one and after 3 months with multi-center setup. What is the most important result? Look carefully, please, to the both creatinine and the donor-derived DNA. No difference. So the extent that it doesn't add anything to creatinine. So this means that in the biomarker, we should be wise and wait a lot of time until we have perfect biomarker, because this is our problem. We don't have troponin like cardiology. Immuno, and the Professor Hani since more than 10 years mentioned the Immuno, and this is the test to measure ATP production by T helper cell. If it is very high, this means that T helper cell is active and the patient may reject. And if it is very low, the T helper is inactive and the patient may get malignancy or infection. This is the simple idea of measuring ATP production by T helper cell ex vivo. This is from cardiac transplantation because I didn't find data in renal transplantation this year. And this is the, as you see here, ATP production is very low, concomitant with infection. But again, there are controversial issues, but there are some centers in the United States working on Silex to measure ATP production. If it is in the window, it's okay. If it is low or high, they deal with immune suppression to avoid both rejection and infection. The last point in the presentation is COVID-19. And this is one of the cohort studies that is still in press in 2 centers and showing that COVID in transplanted patient is bad news associated with poorer outcome, AKI, need of dialysis, and death of the patient, as you see. And in this cohort of patient, COVID-19 was counted in 5%, which is higher than the general population. But the most important data registry published up to date is the French data registry about COVID. So it is French solid organ transplant COVID registry showing and this is because we are speaking about immune suppression. This is how they deal with immune suppression. Anti-metabolite withdrawal, it is the high fraction, this is the number of patients, followed by an mTOR inhibitor as well. Calcium inhibitors, it is left until if the patient is severe, we can stop calcium inhibitor to also. What are the other treatment? These are the repurposed treatment for treating COVID. It seems that they are wise because the percentage of using of these drugs is not large. The outcome, the co-infection, viral co-infection, fungal, a lot of issues, acute kidney injury, replacement therapy, and you can look here to the percentage. Acute kidney injury in 40% of the cases, mechanical ventilation in 30%. So all these are bad. And the most important death, 30-day mortality is 22%. And the probability of severe disease, 30%. Don't forget that is a very good number of transplanted patients affected with COVID. 279, 36 treated at home, and 243 treated in hospital. Some of them have non-severe disease, and some have severe disease. This is one of review article that written by our group at Urology and Nephro Center, and this is one of the proposed algorithm for manipulation of immune suppression in COVID-infected kidney transplant recipient, and this will appear in the October issue of the Journal of Egyptian Society of Nephrology and Transplantation. If we have COVID-infected kidney transplant recipient, if there is no lung infiltrate, continue the same regimen. Have or stop antiproliferative doses in presence of comorbidities for those aged above 65, diabetes, cardiovascular disease, because we wanted to go in a wise way to monitor the patient well and deal with immune suppression in a wise way to avoid rejection. But if there is lung infiltrates, assessing the clinical, if there is no or mild pyrexia or no hypoxemia, continue oral prednisolone, continue tacrolimus with a target 4 to 6 nanogram per ml, and then stop antiproliferative. If there is no response within 3 days, stop tacrolimus as well. If there is lung infiltrate and there is comorbidities, age above 65, diabetes, cardiovascular disease, high-grade fever, hypoxemia, oral prednisolone is given, continue TAC, but to a level 3 to 4 nanogram per ml, and then assess 3 days. If there is no improvement, to stop tacrolimus, because this is a proposed algorithm to deal with immune suppression. If we use any drugs to treat COVID, we should respect the drug-drug interactions, because here, for example, lopinavir-ritonavir, which is Kaletra, and unfortunately, this drug doesn't add anything, and it's better not to be given because it has drastic interaction with tacrolimus, to the extent that some authors, when they prescribe this drug, stop tacrolimus for a while or giving tacrolimus twice weekly. So, and this is an example of interaction. I'm not going to read all these interactions, and you can go directly to this article because it includes all interactions with all anti-COVID drugs with immune suppression. One of the very important review about the COVID-19 and transplantation, as you see from this title, the care of kidney transplant recipient during global pandemic, there are many challenges and strategies for success to face the challenges. And we adopt some of these parameters. So challenges are disruption in the routine care of kidney transplant recipient. Either we set new organization, or patients are afraid to come in gathering to the casualty. Access and adherence to medications, patient-related challenges, and transplant center-related challenges. So what we learned to optimize telehealth, remote monitoring, and strategies of dealing with stress and anxiety and depression. We assure our patients and dispense drug to them and take care of them. I am very proud to be a member of Urology and Referral Center, led by Professor Unaim and Professor Sobha and Professor Ayman Rifai, the current chief of the transplantation unit. And this is from our data. Transplantation started in 1976, and because of COVID, it was locked down on 11th of March. Fortunately, we started last week. We have a case, and we decided to go one case weekly until to probing the system, because we need to monitor the patient before admission by PCR for COVID, and the donor is too, and to put the patient in a safe way instead of this. As Professor Hani mentioned, that we applied all what we know in this education template for the virtual academy. We are proud, and the society is proud by this achievement. It started with Professor Tariq Elbaz and maintained through the years with Professor Gamal, and then pushed forward by Professor Hani Hafiz. Even before COVID, we have webinars. This is the total number that we have: 4,636 lectures, 1,885 videos. And in the era of COVID, this is the number. We have more than 143 Zoom meeting during the era of COVID. So I think this is a very good news, and this is one of the, I don't like to say good face of COVID, but this is what we face the challenge by offering education discussion using distance learning. What I mentioned is just one drop, because immune suppression is very challenging. This is our life in transplantation. And what we know, we try to apply, because knowledge is no value. Knowledge is of no value or valueless if we not practice them. The great aim of education is not knowledge in itself, but to have an action. Thank you very much for your attention, and I'm ready for any question.
Thank you very, very much, Dr. Hussein. Very interesting presentation and very important data about Egyptian patients on tacrolimus as being non-expressive. So do you think that the formula that we start for in most of our patients, giving some calculated doses according to the general rule of, for example, 1 milligram per 10 kilogram of weight, should be decreased in our Egyptian patients? I mean, should we apply less doses than what is in the prescriptions in general? Because as you mentioned, that around 3/4 of the patients proved to be non-expressive. What's your opinion about that?
Thank you very much, Professor Hani. As you know, the limitation of the sample size, it is only the sample size 76 patients. It doesn't tell us about even in Mansoura, it doesn't tell us about 3,000 patients. So, and this is why we should look at this data by a very careful approach. And even we learn it from some of our cohorts that some patients need larger doses, to the extent that we have publications in transplantation about tacrolimus ketoconazole. We tried ketoconazole with tacrolimus to reduce the dose. This means that we have a good fraction of patients in expressive way. But the issue of genotyping, it is appealing. And I remember Ustazna Professor Meher Fouad, when he asked me to prepare a talk about pharmacogenetics of immune suppression since 5 years, and then I repeated the presentation 2 years after the first one. In the second time, I found 10%. In the first time, there is no use of genotyping for immune suppression, except in research purposes. In the second event, I found 10% of the centers all over the world used preemptive genotyping. Because if I know the state of absorption and the state of metabolism, I can individualize my treatment according to the patient needs. I think we are in critical need for genotyping, especially in pediatric group, especially if the test becomes available and cheap. So up to this moment, it is we keep the therapeutic level as we do, and if you لو ساعتك looked at the randomized controlled trial published on this issue, genotype based versus weight based, there is no significant difference in the literature. But if the test becomes very cheap and available everywhere, why I shouldn't look at this, especially in vulnerable group like pediatric, because pediatric patients have a smaller intestine, absorption is less, so it is better to start in adequate dose before waiting a month, for example, to have adequate level.
Thank you very much. And I think we, in this kidney care management program, in the first wave of it, we learned a lot from our 5 very distinguished professors, Professor Ahmed Al-Qurai'i, Professor Maya Hasaballah, Professor Maria Paula Gomez, Professor Magdi Sharqawi, and Professor Hussein Shaisha, that dealt with different aspects of transplantation. In the future, the iBox system, prepared kidney donation, if we applied in Egypt, the overview of organ donation in general, the post-transplant diabetes, and the immunosuppression critical issues. And I hope that all the audience has benefited from this scientific night. And thank you very much for your attendance.
Thank you very much. Shukran jazeela. Shukran.